So we conducted AF Alert because we did an analysis of our performance at prescribing anticoagulation in patients who had atrial fibrillation and were at high risk at stroke, and found that we weren't meeting what we expected for metrics for prescribing prophylactic measures. So we wanted to improve on that, and we had previous experience with computerized decision support at improving areas where there was a clinical guideline that suggested we should be doing something, but we weren't quite meeting the metric. And so we designed AF Alert. So in AF Alert, what we did was we created a computer program that went through the electronic health record. It identified patients who had atrial fibrillation. Then the computer program was able to actually calculate the patient's risk score for stroke using CHADS VASC, which is the risk tool that's validated. And then it looked in the prescription records to see if patients were being administered antithrombotic therapy to prevent stroke. And if they weren't, then the computerized decision support alert fired. We randomized the alert to go to about half of the patients. So if the provider ID number was odd or even, it would trigger an alert. If it were the opposite, then the provider wouldn't get an alert. And so patients actually were randomized by their doctors. And what happened is the alert would notify the provider that the patient was at increased risk of stroke and they weren't being prescribed anticoagulation, and the provider would have a choice to prescribe antithrombotic therapy. They could read about the evidence-based clinical practice guidelines, which included the AHA guidelines and the ESC guidelines, or they could keep going on with their order writing, but they had to explain why they weren't providing anticoagulation. In AF Alert, we actually showed that the computerized decision support alert increased prescription of anticoagulation during the hospitalization, at discharge, and also there was persistence at 90 days. So the alert actually increased the number of patients who were receiving anticoagulation during that whole period. Also, in a secondary outcome, we showed that the alert was associated with a reduction in a composite of heart attack, stroke, systemic embolic events, and all-cause mortality, but it was really due to a reduction in stroke and MI. Well, I think AF Alert is a single study conducted at a single center. We're going to be conducting AF Alert 2, which will focus on outpatients. And I think if we start seeing that this alert continues to have the impact that it does on prescriptions, but also on clinical events, it's something that hospital systems should look at for preventing cardiovascular events in their AF patients. It would be something that a hospital system would consider implementing. We use the EPIC electronic health record, but really any electronic health record could be designed to run a similar type of alert.